All right, so it's 12 o'clock. I think we'll get started. So welcome everyone to our webinar today, The Treatment of ADHD in Children and Youth. Our presenter today is Dr. Russet Killow from the BC Children's Hospital Provincial ADHD Clinic. Dr. Killow, thank you so much for joining us today. My name is Michelle Horn, and I'm the Program Manager for the BC Children's Kelty Mental Health Resource Center. Before we begin, I'd like to acknowledge with respect and gratitude that I live and work on the beautiful, unceded Coast Salish traditional territory, and I give thanks to the Musqueam, Squamish, and Tsleil-Waututh nations. I also wanted to provide a very brief overview of the Kelty Mental Health Resource Center. So we're a provincial mental health and substance use resource center, and we assist families across the province by helping with understanding and navigating the mental health system, listening and offering peer support from parent peer support workers through a collaboration with FamilySmart, and also connecting families to resources and tools. We will put our contact information back up at the end of the presentation, so no need to be having to write anything down right now. I also just wanted to note that this webinar is part of a webinar series. We're currently halfway through this series, and we've already held webinars focused on practical self-regulation tools for children with ADHD, as well as one on the basics of ADHD. As you know, today we're focusing on treatment in children and youth, and in the coming weeks, we have webinars focused on parenting a child with ADHD and supporting children with ADHD at school. There are still some spots left for the upcoming parenting webinar, which will be on February 24th, and my colleagues will be sending out a link to this in the chat for you. All of these webinars are recorded and available on our website at keltymentalhealth.ca/ADHD webinar series. The slides and recording from today's webinar will be available from this link by February 17th, and you'll also receive an email with this link tomorrow, so no need to copy this down. And a few housekeeping notes, then we can get to the presentation. So as mentioned at the beginning, everyone is muted and your cameras are turned off. We can't see or hear you, so you don't need to worry about that. You will have an opportunity to ask Dr. Killow questions after her presentation. So please submit any questions to the Q&A icon you'll see at the bottom of your screen. There has been an option enabled where you can vote for questions that have been asked by others that you would also like to see answered. And there's also an option for you to submit your questions anonymously. Please submit any technical questions, such as issues with audio or any general comments to the chat icon. At the end of the webinar, a survey will pop up, and we would really appreciate your feedback so we can inform future webinars. We also just wanted to note that the information in this webinar applies to the context in British Columbia. If you're in another jurisdiction, please consult your local health authority for further information. It's now my pleasure to introduce our speaker today. Dr. Russet Killow completed her undergraduate and medical degrees at UBC, where she stumbled upon psychiatry in medical school and immediately found her passion. 7 years and 2 babies later, she completed the UBC psychiatry residency. Her work has included treating youth and their families in the BC Children's Hospital Child Inpatient Unit, in the Royal Columbian Hospital Child and Adolescent Psychiatry Outpatient Clinic, in the Surrey Memorial Hospital Adolescent Psychiatric Inpatient Unit, where she was the medical director for 4 years, in the Fraser Health Autism Network, with the New Westminster Child and Youth Mental Health Team, and more recently in the BC Children's Hospital Provincial ADHD Clinic for the last 10 years. Thank you so much, Dr. Killow, for being here today and sharing your wealth of knowledge and experience. I'll now pass it over to you.
Oh, thank you, Michelle. I'm hoping everyone can hear me okay. It's a pleasure and an honor today to be able to speak to everyone and hopefully pass on helpful information for parents with regards to their kids with ADHD. So let's get started. You'll probably find that the first few slides I'm moving through quickly. It's just because I want to make sure that I leave time towards the body of the talk when we're talking about the various medications. Okay, so first of all, though, let me do the land acknowledgement. I respectfully acknowledge that the land I work on is the traditional territory of the Coast Salish peoples, including the Musqueam, Squamish, and Tsleil-Waututh nations. Okay, so these are kind of the learning objectives that I'm hoping we can get through today. Essentially, I'm hoping that we can, the body of this talk is focusing on medications, and I'm hoping to introduce you all to the two classes, both of stimulants and non-stimulants, but also keeping in mind that non-medicinal treatment strategies for ADHD are also very useful. And it's really kind of, it's not an if or. Ideally, for optimal outcomes, you use both meds and the non-medicinal strategies. Okay. I also want to review what we call complex ADHD. That means for individuals who have ADHD plus other comorbidities. And I'll get into that a bit later. But sometimes to get the best outcomes in terms of symptom remission, you need to address the other comorbidities as well. And finally, I wanted to finish by just explaining a little bit about what science is telling us, how medications for ADHD have a neuroprotective effect on brain development. So let's get started. So first of all, just some things to consider. First of all, if you see one child with ADHD, they may present very differently than another child with ADHD. So, not surprisingly, depending on the severity of their symptoms, whether they have all the core symptoms or just one or two, kids can look very different. The other thing is, and I always stress this with parents when I'm meeting with them, is you are their parents, you know them best. I do not force medications. It's my job to let you know what the options are and the side effects and benefits, and then you get to decide whether you want to move forward with medications and which one. Right? So the decision really does rest on the parent's shoulders. As your child gets older, of course, they are more involved in that decision making and have more say. The other thing that I tell parents time and again is recovery from ADHD is not a race. It's a marathon for parents. And so it's really important that you pace yourself. Just, when you're finally at a place where you're wanting to look at medicine, sometimes it takes 6 months or, 9 months or even a year to kind of figure out where the right medication and dose is. And then the other thing is the child's symptoms of ADHD change as they get older. And so sometimes, as they move into high school, you're needing to use a different medicine to help them kind of not be impaired throughout their day. The other thing that I wanted to emphasize, and you've probably heard this already, is that the parent educational programs are a pivotal part of ADHD treatment. All of the scientific studies shows that, now I'm just noticing I'm getting a bit of feedback here. Something is ringing. Oh, sorry, I know what it was. My apologies, everyone. I think I was hitting something at the back of my computer. Sorry about that. So the studies show that therapy for children with ADHD is best done with parents, especially when the children are young. It's hard for them to really engage in individual therapy and to learn the strategies and use them all on their own. So the science shows that it's much more beneficial for parents to learn about ADHD and learn about how to support them at school and how to help them at home and all those other things. All right, this is a quick slide looking at kind of the non-medicinal strategies for optimizing ADHD management. I'm not going to go through this in a lot of detail. As I've already mentioned, the parent education or intervention programs. Some of you may have already seen on the Kelty Mental Health website, we do have a video manualized a website called Rolling with ADHD, and our two psychologists from the clinic have basically made an electronic version of our on-site parent group that we run for 12 weeks. So those kinds of programs are really important. As well, having healthy sleep hygiene, sometimes using melatonin, especially if they're on a stimulant medication, that may be enough to kind of improve their sleep. We know for children with ADHD, we want to make sure that they're having good sleep so that it doesn't impair their focus the next school day. Dietary measures are also very important. Sometimes there are side effects with the stimulants where, they're not as hungry at lunchtime. So it's about building in calories into their breakfast and into their later afternoon and evenings. And rarely sometimes, parents even need to kind of use a Pediasure shake in the afternoon just to help build in those calories. Additionally, use of omega-3 fatty acids, it has been shown to be just good for brain health. Although it is not a first-line treatment for ADHD, it's good for brain development. The omega-3 fatty acids are part of the building blocks of the brain cells. And so it's especially for the young kids where, they're 6 years old and the teachers are concerned about that they're having a bit of focus and impulse issues, but they're too young yet to really look at medicines. Well, making sure that you're giving them an omega-3 fatty acid supplement can be it can help. Other strategies include making sure that they're getting regular cardiovascular exercise 4 or 5 times a week. So that might involve, as the weather gets better outside, that after school is out, they play on the playground for half an hour just so that they can burn off that extra energy that's been storing up for the last 2 hours. Then that will help them kind of be a little more settled at home. The other thing too is looking at within school, do they have an individualized education plan? Are there accommodations in place to help them within the classroom so that their ADHD symptoms aren't impairing them? So things like having regular movement breaks, having fidget tools or wiggle cushions, those types of things can be very helpful. All right. And then one thing I kind of skipped over there was tutoring. We know for children that have ADHD, they're super smart, but how they learn is different sometimes than how the teacher teaches children. There's still a lot of auditory learning in the classroom where kids have to listen to the teacher. And for many children with ADHD, that's kind of quote unquote their weakest link. When learning, having to hear someone talk is really boring. They learn much faster with visual demonstrations and with hands-on learning. So by having one-on-one tutoring, especially with an Orton Gillingham tutor where they use a multi-sensory approach, they do a lot of visual learning and hands-on learning. It helps the young person learn the skills more efficiently. Okay. So, when to try medication? Obviously, if there's evidence of impairment at home and at school, you need that impairment criteria to meet the diagnosis of ADHD. It's also important that your physician that you're seeing has, evaluated for other comorbidities, has also looked at, do they have medical issues that might contribute, like a sleep disorder, or maybe they have a thyroid issue, or they have anemia, or things like that. So it's important to kind of look at those issues to make sure that there aren't any other confounding factors that can be making it look like it's ADHD when in fact it isn't. It's also very important to check in about whether the child has had any previous heart issues, whether they've been followed by a cardiologist in the past, if they were born with a congenital heart defect, those types of things. And it's important just because with the medications, if you've had a previous history, the physicians that are looking at prescribing the medications, they just have to be a little bit more careful. And sometimes that involves getting an ECG, which you can see here on the screen at the bottom, the picture there. And that's a nice laboratory investigation that can be done just to kind of see how the heart is functioning. All right. It's also important to look at the family history to see if there have been any young adults who have been diagnosed with unusual heart rhythms or have had heart attacks in their 20s or 30s, or may have even unfortunately died after really exerting themselves. It's known as sudden cardiac death, and that's what the SCD stands for there. And finally, it's important that the physician looks at, well, is this a child, even before we start medications, who has a lot of trouble with their sleep, or who's quite a picky eater and is very slender? Because knowing if the child already struggles with those issues, it helps the physician kind of guide parents about, well, which medications would be better then, so that it doesn't make these issues even more problematic. And finally, it's just really important that everyone is educated about the various medicines and they understand the side effects and the benefits, and that everyone feels like, they're ready to begin. I don't like starting the medication when a parent feels like they've got, let's say if it's a parent dyad where they're separated and one parent feels like, they're being brought to the medicine table with their elbow behind their back type of thing. We want to make sure that everyone is on board. Okay. So this is a busy slide. I don't want you to get too involved with it. I'm showing it mainly because in the bottom right-hand corner, you'll see where it's taken from. This is through the University of Laval. It's also found on the CADDRA website. So many of you will already be aware of CADDRA. It stands for the Canadian ADHD Resource Alliance. It is the main ADHD national resource. And there's resources for parents, for teachers, and for clinicians as well on that website. So you can actually find this. And I like this because it shows the picture of the pills, and it's a very nice quick reference guide for everyone. All right. So looking at ADHD medications, basically, we divide the medicines into two categories. You have your stimulants and your non-stimulants. All right, and these are the medications that have been found and our evidence-based research shows are most effective for treating the core symptoms of ADHD. So troubles with sustaining focus or attention, difficulties regulating their body movements, or what we call hyperactivity, or difficulty regulating their impulses, right? The stimulant medications, they've been around since the 1930s, so they've been the most well studied. There's more than 350 studies going now that have looked at ADHD. Essentially, ADHD kind of came to the forefront as a possible diagnosis kind of in the early 1970s, even a little bit in the 1960s. And it was in the late 70s, early 80s where we were starting to use the stimulants to treat the condition. Stimulants in particular have high safety ratings. They're safer than a baby aspirin. The same can be said for the non-stimulants as well, the ATOMOXETINE and the GUANFACINE XR. Specifically with the stimulants, over 90% of children will improve with their ADHD symptoms, and up to 50% will, when the parents or teachers redo the ADHD screens, they're in the normal range. So they have a high treatment effect, one of the highest treatment effects of all medications, in fact, not just specifically within ADHD, but just in medications in general. Their treatment effect is somewhere around the ballpark of like 0.9, which is very high. Interestingly, the treatment effect for parent education groups is around 0.6. So there's good evidence as well for those parent educational groups. All right, and then the last point here, these ADHD medications, they don't wear out the heart. they're not bad for your organs or your brain. They can be used safely for years if necessary. Not that they have to be on them for years, but at least you know that, well, if they need to be on them for, the rest of elementary school, it's okay. We just monitor for side effects and make sure that, they're still growing and gaining weight and things like that. There does tend to be a pattern in the teenage years where teens often want to try and go off their medicine and see how they can manage. And in some respects, that it can be a helpful thing because it helps them, especially if they've been on it for a while, it helps them remember that, oh yeah, okay, this is something that I still struggle with, right? So it can be a useful thing. Although I know many parents kind of panic when their teen is saying, I don't want to take my Concerta anymore. Okay. So again, getting back to the CADDRA treatment guidelines, these guidelines are based on all the scientific evidence, and they, with any kind of treatment guidelines for any condition, we categorize them kind of into first line, second, and third line, with the first line treatments having the highest level of evidence. Second line, there is still some good evidence, but it's not as it's not as abundant as the first line. So what you'll see is with the first line treatments, it's all of the long-acting stimulants. I have them all listed there: Concerta, Bifenton, Foquest, Adderall, and Vyvanse. By long-acting stimulants, these are medications that last at least 10 hours a day. And with Foquest, it currently is the one that lasts the longest. It's 16 hours a day. Vyvanse is about 13 or 14 hours a day. So usually the Foquest and the Vyvanse, those are ones that adolescents or adults use because they need to still have focus in the evening to do homework and things like that. And understandably, with children, sometimes they don't do well on those two because they last too long. And then they're not eating lunch and they're not eating dinner, and they're sleep deprived because it's taking them a lot longer to fall asleep. So that's where the physician, you kind of tailor things to what the child or adolescent needs. Second line treatments, certainly the non-stimulants, the ATOMOXETINE and the GUANFACINE. And also included in here are the short and intermediate acting stimulants. So the short acting, you guys may have heard of, Ritalin and Dexedrine. Those are the short acting versions of the stimulants. They last up to 4 hours, which isn't long. And so those were the medications that were first made available. And what was happening is you'd have to dose them multiple times a day. The intermediate acting stimulants came next, and those ones last somewhere around, 6 hours. But again, it wasn't long enough throughout the school day. And so it's only been in the last decade or two where the long-acting stimulants have been available, and it kind of covers the youth throughout their whole school day. All right. So the positive effects of stimulants, as I've already mentioned, the studies show that it definitely improves their concentration and their ability to sustain attention. It improves their impulsivity and hyperactivity so that they go down. And they're often more productive in class. You'll find that, especially with the elementary children, that they may not recognize this difference. They don't have that self-awareness cognitive skill yet to do so. But sometimes what they do notice is that, well, the teacher doesn't harass me anymore. Or they may notice, well, I'm able to get more work done in class, so I don't have as much homework. All right, and sorry, I just noticed there's some kind of notification right at the middle of my screen. All right, and then the secondary effects, which are just as important. As I mentioned, there's the increased work productivity in class. It may also play out as well in terms of their accuracy. So you may see a little bit of improvement in their spelling or in their math work or things like that. It reduces the oppositional symptoms and the aggression. Um, Sometimes it improves their penmanship. Um, and what happens is, as the children are on this medication and things are going better for them at school over a period of several months, they start to feel better about themselves. Their self-esteem improves and their confidence improves. Um, and for some children, they also do better with maintaining friendships. Um, there may also be some improvements in their performance in sports. And certainly with the adolescents and adults, not children, because they're not driving yet, but you'll see improved driving performance. They have less speeding tickets, less MVAs and things like that. And it also improves the risk of substance abuse. Okay. So the myths about stimulants, right? Because aren't stimulants like kiddie cocaine? I'm sure many of you have run across that somewhere on the web. The quick answer to that is absolutely no, right? The stimulants are not addictive when they are used as prescribed. So all of the stimulants that are available here in Canada, you ingest them and swallow them. They are slowly digested and released in your stomach and small intestine, and you get a gradual raising of the blood concentration level of the medication. And that then crosses the blood-brain barrier and has an effect on the brain cells. So where you see people getting high or getting addicted is when they are using these medications in a way where they enter the bloodstream very quickly, like within 30 seconds. So with some of the stimulants like bifentin or Adderall, if you grind them up and snort them, yes, you can get high, but that's not treatment of ADHD, right? Because with ADHD, the medications work gradually. You get to a steady blood concentration, and all it does is it replaces the dopamine and the noradrenaline that's lacking in the frontal lobe brain cells. When you snort stimulants, you get a huge rush of dopamine and you get high. So hopefully you guys understand the difference. And certainly I can address that more in the question and answer period later. Following along this line, there's a number of studies now that have shown for children and youth that were diagnosed with ADHD and did use medications for it, later in adolescence and adulthood, they have a decreased risk of substance abuse issues. I will be addressing this a little bit more later on. We still see in the media, or even a few years back in the, I can't remember if it was the Sun or the Province, there was a concern about, well, ADHD is being overprescribed, or the ADHD meds are being overprescribed, and that is just not true. We know that the prevalence for children and teens with ADHD is 5 or 6%. It's actually even a bit higher than that. It's more like 5 to 8%. And the prescription rates in the province consistently are around 4%. So we're still not catching all of the ADHDers who might need medications. I hope that helps dispel that one myth. And again, if you have just ADHD and nothing else going on, if you use medication, it helps reduce their aggression and oppositional behavior. Sometimes, and we'll get to this later, if they have other comorbidities, it can cause some more irritability in the afternoon or evening. And when the kids get really irritable, and if they're hangry and everything else, sometimes they get aggressive. But it's because of the combination of the other comorbidities with the ADHD medication. And as I said, we'll talk about that later. Risk of seizures is very low. And occasionally I will see, it's often the younger children that when we're just starting medications, there might be a little bit of tics that come out. The stimulants don't cause tics, but they unmask them. So if the child has a genetic vulnerability towards tics, sometimes it comes out. All right. So stimulant side effects, moving on here. The most important thing to know about this slide is that having trouble falling off to sleep or waking up a lot at night and loss of appetite are the two most common side effects. Up to 50% or more of children experience this. All right. The other things happen less frequently. It's important that the physician kind of is aware of, if your child already struggles with some of these things before starting an ADHD medication, it's important to let the physician know so that they can tailor which medication might be the better one to use. Adverse events are a little bit different than side effects, or I've called them here adverse side effects. These are the really rare side effects that have a significant risk of harm. So with the stimulants and with the non-stimulants, it really is about, whether does it affect their blood pressure or their heart rate. Generally speaking, for kids, as long as they don't have any previous heart conditions, it's not an issue. But sometimes, very rarely, there might be a child where they may have a very mild abnormal heart rhythm that just was not picked up in previous doctor visits. And then when you add in a stimulant, it might exacerbate this a little bit. So it's important that the physician, checks their heart rate and their blood pressure and things before starting the medication. The issue about suicidal thinking is also a very rare concern. And in fact, often I see the reverse, where when they have a lot of difficulties at school and it's very frustrating and they come home and they've just had it with their day, that is where during a meltdown at home, they may kind of say, I'm stupid, I hate myself, life is too hard, I just wish I was dead. Those things can occur. Often when they are having more success with their ADHD symptoms, things are going better with getting work done in class, having friendships, this decreases. So it's something to be aware of, but I don't think it's something that parents, should feel like, well, we definitely can't use ADHD medications because of this risk. Most pediatricians or psychiatrists like myself were already screening and gauging about any of these kind of potential adverse side effects. All right. What I'm wanting to show you is just a little bit, I like this graph because it shows how the long-acting stimulants versus the short-acting stimulants work. So the blue dotted line here is the fast-acting Ritalin. And so you'll see this on the x-axis is kind of time duration. On the y-axis would be kind of the blood concentration levels. And you'll see with the short-acting, right, you get these peaks, but then it wears off quick after 3 or 4 hours, then another peak, and this is where you're kind of dosing it 3 times a day. This is a bit of a yo-yo effect. And for those adults who may have had ADHD and were treated with these medications in the 80s or 90s, you may recall feeling like, I felt like a zombie for a couple hours, and then I felt like I was crawling out of my skin because I needed to move. This was not effective treatment of ADHD. This other graph here, it's the green and the purple, is kind of, I should clarify here. The green dotted line here is the intermediate acting form of Ritalin that lasts 6 hours. And it does better at having kind of a steady concentration level. But when it wears off, it dips down pretty quick. And that's where you can get a little more rebound. When the medication wears off quick, that's where you can get this effect called rebound ADHD. And I'll explain that in a bit. Whereas when you look at the purple line here, this is the Concerta. And you'll see its wear off is more gradual here at the end. So you'll see, you know, by the time it's 10 hours, they might be a little more distracted. They might get a little more busy in their body movements, but you're not seeing this big change of ADHD rebound where they're like, you know, the Looney Tunes character animal, you know, or the Tasmanian devil that kind of just whirls around the room unstoppable and causes havoc everywhere it goes. That's ADHD rebound. Okay. All right. And then I just wanted to give you another slide showing the capsules of bifentin. So both the Concerta and the bifentin are long-acting forms of what we call methylphenidate, or sometimes I say Ritalin because it helps parents. Methylphenidate's a long name. But when you look at the stimulants, you've got either methylphenidate-based or amphetamine-based. And for children, I tend to use more of the methylphenidate. I find that the amphetamine-based ones like Adderall and Vyvanse, if kids have anxiety, it tends to rev up their anxiety a little bit. So I tend to try and stick with bifentin or Concerta if we're going to use a stimulant. All right, so managing side effects. Ensure compliance. Make sure that your child is taking it as directed. And that's usually, so where this comes an issue for kids is some kids can't swallow pills yet. And so we get around that by using, like, for example, bifentin. You can open the capsule and sprinkle the granules onto a spoonful of yogurt. And then you just have your child swallow the yogurt. With teens, sometimes that don't want to take their medicine, but parents do, sometimes the teens can get pretty good at what we call cheeking their meds, where you think as a parent that they're taking them, but later they go to the bathroom and spit it out. So it's important for your physician to know, yes, they are taking it, or if they're not taking it. If there are side effects like trouble with sleeping or appetite suppression, first thing we often do, especially with the stimulants, is we adjust the dose, right? We might lower it a bit and see if that helps. I've already discussed rebound, right? So if parents are reporting rebound and let's say their child is on a short-acting Ritalin or maybe an intermediate-acting Ritalin, well, that would be where we would think about, well, you know what, I think we really need to move to a long-acting stimulant like Concerta or bifentin, or maybe we need to look at a non-stimulant like ATOMOXETINE or GUANFACINE XR. It's also really important to look at what are the other issues that might be going on and look at whether these need to be treated, perhaps with other medications. And then it's always important to look to see, especially with the teens and the adults, sometimes with the tweenies, looking at, you know, are they experimenting a bit with, you know, e-inhalers or using a bong and smoking pot or things like that. And it's important that the physician from time to time just kind of checks in about, you know, is there any chance that, you know, there's pills that are going missing, and you know, are the kids giving them to their friends? This is more sometimes an issue with teens. I rarely find it with children because usually parents are giving their kids their pills every day. And then psychosocial changes are really important to look at as well. Kids with ADHD are very sensitive to any changes in their class environment or the home environment. So sometimes parents may think that, well, their stimulant isn't working anymore, but later on find out, well, no, the teacher has been away for the last 2 weeks on sick leave, and they've had a different substitute teacher every day, or the EA has been removed from the classroom, or there's little Johnny that's been really bullying them at lunchtime, and it often takes kind of several days or a few weeks before this, you know, your child eventually starts talking about it. So with your physician, it's always important for to kind of just check in and find out if there's any changes at school. Similarly, if there are any changes at home, you know, whether loss of a loved one, or mom and dad have been, or mom and dad have been fighting a lot, things like that. And again, the things that I talked about before with sleep and with appetite, right? Those are things that commonly occur with stimulants, but we can commonly kind of improve them with using melatonin 2 hours before bedtime, or making sure they have lots of snacks in the late afternoon and evening, and building in calories, like, so using higher fat dairy, or using Pediasure, or smoothies with ice cream, or whatever you need to get the calories into them. I often joke with parents and say, you know what, don't get too bogged down about how healthy their eating is at this time. It's really about getting the calories into them because of the side effects of the stimulants. When they turn 25, that is when you can pay for a dietitian consult and maybe even a personal trainer consult. And hopefully by then their frontal lobes are fully mature. They'll be a little more engaged and motivated to start changing some of those eating and exercise habits. Okay. All right. So we've talked about the stimulants. Let's talk a bit about ATOMOXETINE and GUANFACINE in particular. I'm not going to talk too much about clonidine or risperidone. If there's specific questions at the end, maybe I can talk about them then. So looking at ATOMOXETINE, or the other name is Strattera, that's the brand name. It is a medication that is, it's not a stimulant. It's what we call a serotonin reuptake, let me back that up, a selective norepinephrine reuptake inhibitor. So this is a medication that you have to take every day, and you have to be patient and wait for about 6 weeks before you know what the full therapeutic effect is. That's different than the stimulants, where the stimulants start working within 20 or 30 minutes. And most parents can tell the exact minute when the medication stops working. So these ones, the effect is much more gradual. There are things like, in terms of common side effects, sometimes kids do get a bit of a decreased appetite. I tend to find that it's a little bit appetite neutral compared to the stimulants. Sometimes they can have a little bit of stomach upset or some nausea. We avoid that by starting at the lowest dose and gradually increasing it. Similarly, for concerns about a bit of a headache or some irritability, those types of things, by starting at a low dose and gradually increasing it on a week or every 2-week basis to kind of your minimal therapeutic dose, that's how we avoid side effects. And I've shown the capsules there. That's the lowest dose, the 10 milligram capsule. So for most children, you would start them on the 10, and then you would move up gradually to the 18, and then maybe eventually to the 25. And we dose it based on side effects, therapeutic effects, and their weight. Very rarely you can have liver dysfunction or some severe rashes. There is also a caution about agitation or suicidal thinking. It's important for physicians to talk with parents and the youth before they start it. The suicidal thinking, if this becomes an issue, it's often around kind of week 3, week 4 of being on the medication. If they go on to experience it, we stop it, and it's kind of considered a drug allergy. You don't go on it again. Okay, but just so you're aware, the risk of that is really low, like I'd say less than 5%. And by starting at the lowest dose and gradually increasing, it reduces the risk even more. All right, so guanfacine XR, the other name is called Intuniv. It is an alpha-2 agonist, and it works on the noradrenaline system. It has a few ways that it kind of increases noradrenaline levels in the brain cells, and then you see reduction of ADHD symptoms. This medication also, you have to be patient and take it every day and wait till about 6 weeks to know what the full effect is. It's good for the core symptoms of ADHD. It also helps with emotional dysregulation. So ADHD youth, their mood can change multiple times a day. I kind of call it the roller coaster effect. And when they're young, they're not as psychologically minded. So they're not able to tell you necessarily what made them really grumpy or what made them sad or things like that. And it's in part just because they've got so many thoughts going on in their head that it's hard to connect the dots, so to speak. This helps the roller coaster kind of become more of a smooth ride, like a Sunday drive. So it can be very helpful that way. It doesn't suppress appetite. It doesn't cause or unmask tics or make tics worse. And it doesn't cause insomnia. And so for some children, in fact, they can be given it at dinner time, and then it helps with them falling off to sleep at night. When you first started, sometimes it can cause a little bit of afternoon sedation. Generally speaking, we aim to start it in the morning. And so the sedation effect sometimes happens in the first 2 days around 4 to 6 hours after taking it. So it's a good thing to start it on the weekend so you can kind of check in and see how they're doing. Usually after a couple of days, you can, that effect wears off and then they're good to go. If that effect still happens, then I usually recommend that they take it at dinner time and do that for a couple weeks and then try and switch it back to the morning if possible. The only reason why optimal dosing is in the morning is because this medication, it lasts up to 24 hours a day, but it's most effective in treating their ADHD in the first 12 hours after taking it. I should have mentioned as well with the ATOMOXETINE, it also lasts 24 hours a day. So and with the guanfacine, it is a bit expensive. So you want to, make sure you're reaping the benefits, so to speak, of the cost. So it's better to take it in the morning. All right. And uncommon side effects, sometimes children can get a bit of dizziness when they're standing up. It's important for the physician to monitor their blood pressure and their heart rate, because if they're experiencing some dizziness, this might be a sign that their blood pressure, when they first stand up, it drops a little too low. If they do get this dizziness, sometimes we have to decrease the dose because we don't want them falling. We don't want their blood pressure dropping a little bit. I should note too, when they stand up, it's called an orthostatic change. Their blood pressure drops just for a few seconds, and then it goes back up to normal. So it's not like they're going to, have a heart attack or something like that. But still, we don't want them to be falling down or fainting or things like that. Okay, so looking at comorbidities, and I'm aware of the time, as usual, when I do this talk, I'm always running a bit behind. What I want to really emphasize to you guys are, you'll notice here oppositional defiant disorder. This slide, in essence, is showing you the co-occurrence of ADHD and the other condition. So not surprisingly, you see this ODD very commonly, like probably 80 to 90% of patients with ADHD may have some ODD. I don't like to focus on the ODD. First of all, the acronym is odd, and over time, your kids may hear you talking to the teacher or their doctor about ODD, and they say, I'm odd. Oh, well, what do you think is going to happen to their self-esteem? And as they get older, they start to already see that they're a little bit different than the other kids at school. So, and ODD is really like saying you have a tummy ache, right? We know that there can be lots of causes for a tummy ache, and I would rather focus on the underlying causes so we can get rid of the tummy ache. So, and the underlying causes for ADHD are several, the underlying causes of ODD are several and include ADHD, anxiety, depression, sensory processing disorder, learning difficulties, autism. There's a number of things that can contribute to that oppositional behavior. So it's important to figure out what are the roots of this behavior and address those instead. Okay. I also wanted to just show you as well that, you know, mood disorders and anxiety, mood disorders meaning primarily depression, and anxiety and learning disorders are the big issues here. Okay, so when we look at youth that may have some worry issues and they may have ADHD, it's important for you as parents to understand that these young people are not going to be tearful or fearful. Very rarely are they tearful and fearful. When they get worried or stressed, they get irritable as grumpy bears. They're the not doing it kid. They don't have a lot of strategies to deal with their stress. The only strategies that they really have are avoidance and denial. And that's why you get the oppositional kind of behavior. So I often see that anxiety is in the mix because ADHD interferes so much in their whole school day, academically, socially with friends, and emotionally. So it's not surprising when they are experiencing anxiety. Sometimes there may be children or certainly teens, sometimes children, that might have a bit of depression as well. And so it's important to get the best outcome to look at treating their anxiety or depression. Certainly if they're really go slow, and then you, as those symptoms settle down, you might need to adjust their ADHD medicine a little bit just to kind of optimize their ADHD management. But usually using 2 different classes of medications can be helpful in getting them functioning better. If their anxiety or depression is mild to moderate, but the physician's not able to get their ADHD medication to a therapeutic dose because of side effects or things like that, and especially for the younger children who they can't really engage in the CBT. CBT stands for cognitive behavioral therapy. It's a type of talking therapy. And for kids with ADHD, it's hard to sit still and listen to your clinician kind of going over strategies to deal with your anxiety. So for the mild to moderate anxiety or depressed child, I often recommend starting an SSRI because we know that they're not going to be able to engage in the CBT at their age. And so we really do need to kind of bring their anxiety level down so that their ADHD medication can work properly. Okay. And then the last thing I mentioned here are just about CBT options. You may have heard of some of these, Taming the Worry Dragons group, the Cool Kids group. These are programs that are offered publicly, either at your local child and youth mental health team. Some of the school counselors use them at school. We run some Taming the Worry Dragon groups for children and teens here virtually these days because of COVID. Additionally, you may decide to hire a private counselor that can do this stuff with your child. There is also mindfulness-based cognitive behavioral therapy, which has been quite promising for teens and adults with ADHD or anxiety or depression. I'm really sorry. I know we're over time. I'm going to go through these last slides very quickly. This is a very nice slide that just shows you how the effect of using medication in childhood and teenage years reduces your risk of substance use as an adult. So the green block here is adults with substance use that never had treatment of their ADHD as a child. The red is those adults with ADHD that did have their ADHD treated as a child. And what they're measuring in the study here is the prevalence of substance use disorders in these different groups. So you can see that with the treatment of ADHD, the adults are almost normalized to the control group. So, and this effect has been replicated in many studies. So it's very important. If you as a parent, if there's a strong history of substance use in your family, If your child has ADHD, this is the time to be looking at how we can help avoid their substance use later in life. Okay. I'm sure I'll get questions about BC Bud. Just to really comment in short as possible, there's no studies to show that using medical marijuana is helpful in reducing ADHD symptoms. It doesn't matter what you see on the web. There's no scientific study to support this yet. Okay, and keep in mind that even though, you know, it's an alternative treatment and it's natural and things like that, there's a lot of companies that are making tons of money in medical marijuana. And so it's not surprising when you look on the web that they have invested interest in making sure, like, it's marketing, right? So you do need to be objective when you're looking at those websites. And in fact, when we look at teens that use marijuana, it actually makes them look more like they have ADHD. It impairs their working memory and their processing speed. So they don't learn as quick, and they're slowed down in their learning. And with CBD oil, which is low in THC, again, the jury's out really in terms of, is it helpful with ADHD? CBD oil has been touted to have a lot of anti-inflammatory effects. So it might be useful for some conditions where there's a lot of inflammation, but with all of the hundreds of studies on ADHD, there has never been any concern about it causing inflammation. It's really about neurohormonal differences, right? The levels of dopamine and noradrenaline are too low in the frontal lobe brain cells. So I don't know that CBD oil is really going to be quite promising in helping with ADHD. It's still too soon to know. According to Health Canada, physicians should not be prescribing CBD oil to treat conditions like ADHD. There is an argument for, severe and acute conditions like treatment refractory epilepsy or terminal cancers or things like that, but there's no recommendations to treat ADHD with CBD oil. The other thing that I just wanted to say, I had one patient who has a very complex cardiac history, was born with multiple congenital heart defects. And his pediatrician had actually said, you know what, why don't you try some CBD oil? And so they tried it, and lo and behold, because this kid is on warfarin to make sure his blood doesn't clot, and CBD oil affects warfarin. So for the first time in years, his INR was abnormal. Right. And they needed to get it treated right away. So CBD oil can interact with medications, and you don't know what the effect is going to be. All right. And just lastly, the neuroprotective effect of stimulants. And also it's looking the same for guanfacine XR. These medications are healthy for the brain. So I'm going to show you here. This is a functional MRI scan looking at the brains of ADHD youth and normal controls. They're getting these youth to do a focused task on the computer while they're in the machine taking the scans. And what you'll see here in the normal controls, here in the prefrontal cortex, while they're doing this focused activity, the anterior cingulate cortex is lighting up. So what these scans show is brain activity, all right? They're not showing like masses or abnormalities. They're showing healthy brain activity. And so this is the area that's supposed to be lighting up. When you look at the ADHD group, this area isn't lighting up. Instead, they're using more lateral older neuronal pathways that are slower. And this is what we see with ADHD youth that aren't on medication. When they're having to do the same tasks in the classroom, they have to recruit a lot more neural pathways, and these neural pathways are slower. So it's not surprising that at the end of their school day, they're exhausted, their brain is tired, and they melt down when they get home. And, dad or mom says, "Hey, can you make sure you take out the garbage?" Or their little sibling comes up and, wants to play with them or something, and they just don't have the patience. So interestingly, I don't have a slide for this, but in these studies, they then do another scan of when the ADHD group is on medications like a long-acting stimulant, and their scan looks like this. It normalizes. So this, we know for ADHD youth, their brain's development is a little bit slower, especially when looking at pathways involved with social and emotional development. So we need to encourage that growth as much as possible, and using medication is one way to help that. This slide also, it's a PET scan, which is another form of a brain imaging scan. This is the ADHD group, right? Sorry, my mouse went there. This is the ADHD group. This is the normal group. The red lighting up is healthy brain activity in the frontal cortex, and you're not seeing it in the ADHD group. And again, it normalizes when the stimulant is added. Okay. So, with the conclusions today, I know it was a whirlwind. I'm sorry, there's just so much information to get through. Hopefully, I've given you a bit more information about complex ADHD and how we want to use all strategies that can give the best outcome and the best level of function for your child at school and at home and in their extracurricular activities. I've also discussed a little bit about other comorbidities and how it may affect how your child responds to their ADHD medication, and that over time we know the symptoms of ADHD can change a bit, and understandingly then sometimes their medications have to change a bit as they move into the teenage years or into adult years if they decide to stay on medicines. And I've reviewed, hopefully, so you're a little more familiar and comfortable with the different classes of ADHD medications, and a little bit about CBD oil and how ADHD medications are neuroprotective for the brain. And I ended with this slide because I just thought, ADHD is messy. For you and your child, there's going to be years where it's messy and it's hard. But it is a beautiful and rewarding process. And these children, when they grow and mature and in their 20s, they have so much to offer society. We need to support these young people so that they can be the stars that they're going to be in their adulthood years. Our society needs adults with ADHD who can think outside the box and be creative and kind of help move our society forward in its progression. So thank you very much, everyone, for your attention. I apologize about going over. I'm happy. I don't know in terms of whether we can stay a little bit later to answer questions. I'm happy to do so. I'm going to pass this over to Michelle again. This last slide is just a quick reference slide to various ADHD resources. Kelty Mental Health website has similar lists and so forth. So I'll finish with that. Thank you so much, everyone.
Thank you so much, Dr. Killo. So much information that you packed into 1 hour. So well done.
My pleasure.
So do you have 5 or 10 minutes to stay over to answer a few questions that came through? Okay, and I will just mention for folks that need to leave now, if we didn't get to your question, there were so many good ones that I saw coming through the Q&A, over 70 questions. Feel free to email us at the Kelty Center, and we'd be happy to help provide you with information or resources or peer support through the Kelty Center. And Dr. Killo, would you mind going to the very last slide that just has the
yes,
information
right
on it? and just the one right after this, just for folks that need
Okay.
to be right on time so they can access our contact information there and jot it down. Okay, so with no further ado, we'll jump into the questions and we'll get to a few at least. And again, feel free to email us if we didn't get to yours. So the question that the most people wanted answered, 36 people said they wanted this one answered, was about melatonin. And I saw a few other questions that were related to melatonin as well. So if you could speak a bit more about melatonin. So for example, can a child take too much melatonin? Is it okay to take every day? Are there long-term impacts? How early can a child
really
start
good questions? Yeah. And I get asked this a lot. So I'm glad you guys brought it up. So melatonin is something that our brain makes. Deep in the deep part of the brain stem here, there's a little gland the size of the end of your pinky called the pineal gland. And it's the dimming of the light in the evening that gets that gland to start making melatonin. So we know for children with ADHD, that how their brain works sometimes can be a little bit funky. So they may, with their pineal gland, it might take a little bit more of dimming of the light before it finally kind of clunks in and starts making melatonin. Additionally, if you're adding in stimulants, sometimes it makes it harder for them to fall asleep. So this is where it's about the sleep hygiene and the use of melatonin. By sleep hygiene, the Kelty Mental Health website has a really good web page on sleep hygiene that can go in more detail. But essentially, what you want to be doing in that hour before it's bedtime is that you are allowing that natural process of the dimming of the light to happen as much as possible. So it's really important that they're not on screens in at least that last hour before bedtime, because the screens they emit this blue wavelength of light, and that tricks that pineal gland into thinking it's only lunchtime, when in fact it's 9 o'clock at night. So that's the first step, is to make sure that they're not on screens. With teens, it's tricky because I know they want to text with their friends before they're going off to bed and stuff like that. Even if you can get them, it's not ideal, but it's better than nothing. If you can get them to use the nighttime settings. I've heard of some parents asking their kids to wear sunglasses when they're looking at their screens in the last hour, because it filters out some of that blue wavelength of light. That might help a bit with their pineal gland to start making the melatonin, because we want to maximize how much that gland is making the melatonin. There have been concerns raised from a few endocrinologists about, what could be the long-term effects of kids using supplemental melatonin? Are they going to down-regulate their own production? They're doing studies now to kind of look at this. One way to make sure that they're still making their own melatonin is not having screens in that last hour, and making sure that they're doing, a quiet activity with the lamp on in their bedroom. Whether they're reading, whether they are playing with Lego, whether they're listening to music or something, but having a dimly lit room will help with that. So that way you're still stimulating their own production, but you're also adding in the supplemental melatonin that they need. In terms of is there too much melatonin? The quick answer to that is no, right? It's not like kids can overdose on melatonin. What I find is if, for children in particular, there's no point in going beyond 10, because you're not going to see any further benefit beyond 10. With adults, there may be some benefit, of going up to maybe 20 milligrams or something like that. As well, there's now available, they'll have combination melatonin where there's a bit of the short acting and some of the controlled release. Because melatonin itself, its duration of action, it only lasts about maybe 3 hours or so. So it's relatively short acting. So if your child is having difficulty with waking up in the middle of the night repeatedly, using regular melatonin isn't going to help that. That's where maybe either using the combination melatonin or whether you use just the controlled release melatonin itself. And you might see that helps them stay asleep a bit better.
Great.
Hopefully that helps. And certainly, I endorse use the smallest amount of melatonin that you need, but, wait a couple nights. And if it's not helping enough, then move up to the next dose. The goal should be that once lights are out, your child is asleep within 30 minutes. Anything beyond 30 minutes is a sleep problem, which could affect their concentration the next day. Okay.
Thank you so much. Okay, and the next question is one that we actually hear from parents a lot. They're wondering about taking breaks from medications. Is that necessary or helpful?
Yes, I recommend to families, sorry, that didn't come up in the talk. It's a common question. So drug holidays can be very useful for the stimulants. And I do recommend that, especially for a couple reasons. One, especially in the summer where the sun's out, there's a lot of vitamin D being given by the sun. So kids do a lot of growing in their bone growth during the summer. So this may be a good time to kind of have them off the stimulant. It was in one of my slides about side effects. I didn't go over it because I was trying to be careful about time. Generally speaking, the stimulants don't have a huge effect on height. Roughly, they've done there's been lots of studies done, and with the more recent ones, what we recommend is, the studies show 80% of young people that are using stimulants with consecutive years, 80% of them meet their expected height. There's only 20% of these young people where they're not meeting their expected height, and it plays out to they might end up being 1 or at most 2 centimeters shorter than physicians would have expected given the parent's height. And so, 1 or 2 centimeters, unless your child's going to be like playing professional team sports, is probably not a huge deal. If it means that, they can function better and have more success at school. But you as the parents get to weigh that out, right? But so the summer breaks are useful because they can really grow in height, and they also, they'll be eating a lot. And I find generally with children, when they get to eat at home at lunch, even when they're on their stimulants, they'll often eat a little bit more than they would eat at school because the school lunches are boring. Right? We as parents, we're so busy with our jobs, and we get so excited when we found a lunch that our child will eat. But ADHD kids, they get bored after, a couple weeks or a month, and then they don't want to eat it again. And so it's always you're kind of chasing as a parent, okay, well, what lunch are they going to eat now? You're always looking for new creative ideas. So the summertime is a good time to take them off of their medicine so that they can, I don't want to say bulk up, but many young people tend to be slender when they're on the stimulant. So it just kind of helps give them a bit of a reserve so that when you're starting the stimulant again come the fall, you've got a little bit of reserve so that if they're starting to kind of slender out a little bit, you're not getting into a situation where they're losing weight or things like that.
Great. And do you have time for one more question? Great. Okay. So there was one question about resources around diet. But I think you talked a bit about the diet. I don't know if there's any other resources that you could point people to very quickly, and then maybe one more question after that.
Sure. So I don't know if I haven't looked to see if this is on the Kelty website, but I'm aware of somewhere. I know in our ADHD clinic manual, we've got a link to kind of a quick link about how to just add in calories, right? So making sure that they've got a big breakfast if you can. Adding some protein into that breakfast is great because the protein helps your body just to kind of slowly metabolize the complex carbohydrates. So you're not getting these big ups and downs in their sugar levels and stuff like that. And making sure that lunch, there's something quick and easy to eat. Because we know at lunchtime, they just want to get outside. So really what I tell parents, of course, it's better if they can eat their whole lunch. But if they're not doing that, then making sure that, they've got something like a yop or something that they can drink or a snack that's really quick to eat that's going to give them some gas for the afternoon for their brain. What their brain needs is carbohydrates so that it can function. And then after school is when they can eat the rest of their lunch, or they come home and you can make them a snack. And ideally, yes, if you can keep the snacks healthy, that's fabulous. But you have to be careful about the battles that you pick. And if you're already dealing with battles of, well, no, you have to go to school even though you don't want to, and you have to go to bed at this time, I don't recommend making food a battle, saying, well, you have to eat this healthy food. You can't have a granola bar right now or a muffin or something like that. I would recommend that you don't make food a battle. It's just not worth it, because we already know in the afternoons and evenings, they've had a full day of school. They're a little bit grumpy and tired. You don't want them to be hangry and have these full-on meltdowns and explosions.
Great. And we do have a section on our Kelty website on eating well that has information about medications and how they impact appetite, and some tips for parents. So one of my colleagues can put that link in the chat. Okay, so final question. Is it okay to supplement with magnesium?
Right. So I don't think it's a huge issue. I know that many naturopaths recommend using some mag sulfate. And what I would recommend for parents is you may actually want to consult with a naturopath and get a little bit of direction about that. Certainly there's some magnesium and multivitamins, and you may feel like, well, let's just use a multivitamin and see how that goes. If you're wanting to kind of start using mag sulfate, it might be better to seek out some type of care provider, whether it's your pediatrician, your family doctor, or a naturopath, just to find out, well, what would be a good dose in terms of magnesium sulfate. The studies don't really support that magnesium sulfate provides a huge benefit. But it's tricky because, it's very expensive to do the proper kind of evidence-based studies. And for the companies that make these supplements, like some of them are kind of smaller companies that they don't have the money to put into the studies to be done properly. So it's hard to know. It's just that it's been difficult to do the proper studies, and that these supplements can really provide some benefit. So certainly if you're, as a parent, aren't yet really wanting to go the medication route, I would certainly, see a naturopath and look at, magnesium sulfate, ginkgo biloba. Sometimes they recommend cyanobacteria, things like that, in addition to omega-3 fatty acids. And certainly there is some evidence-based recommendations that omega-3 fatty acids are helpful for brain function.
Great, thank you so much. So unfortunately, I don't think we have any more time for additional questions, but again, feel free to email us at the Kelty Center. We have parent peer support workers and staff who are able to provide resources, information, and peer support to you. Thank you so much, Dr. Killo, for your time today. So much information.
Thank you for having me.
Thank you to all of the parents and caregivers and other attendees who were with us today. We really appreciate you joining us. And just a reminder that once we end the webinar, a survey link will pop up. We would really appreciate your feedback as we think about future webinars and how we can improve them. And you will also be getting an email tomorrow with all the resources that were mentioned today, as well as a link to the PowerPoint slides. So wishing you all a nice afternoon. Thank you.